Hello everyone, my name is Hillel Gluch. I'm a podiatrist and I would like to present a short video on the topic of non-surgical treatment of onychocryptosis, ingrown toenails. This video is aimed at podiatrists and other medical personnel who come across ingrown toenails in order to give perhaps a different perspective in regards to the non-surgical treatment of ingrown toenails. First, I would like to give a bit of a background of who I am. I grew up in Johannesburg, South Africa, and qualified as a podiatrist in Johannesburg in 1996. In 1997, I immigrated to Israel, and in the same year, I opened up a private practice. After a few years of private practice, I started working also in the public sector, what's called in Israel the Podiatrist system. Here, patients can come to the clinic without the need to pay. Israel has 4 main Podiatrist companies, and every citizen in Israel belongs to one of them. Now, unfortunately, Israel still today has very few podiatrists, and back then had even fewer. So at one point, I was working for 3 of the 4 Podiatrist companies at the same time, including a diabetic clinic treating high-risk patients with all degrees of ulceration, where I worked for about 14 years, and running from clinic to clinic, in addition to maintaining a private practice. In addition to all of this, when I came to Israel, I also volunteered to work as a podiatrist for the Israeli army, where I worked for many years, 1 whole day every 2 weeks, in the surgery department, treating primarily soldiers with ingrown toenails. My clinics in both the public sector and in the army were very intense, often having 6 patients booked per hour, sometimes even more. I continued working like that in multiple clinics for quite a few years. I have since then calmed down quite a bit, and today work for just one of the Podiatrist companies, in addition to maintaining my private practice in 2 locations. However, for that one Podiatrist company, I work in 5 different cities around the country. Because of the dire lack of local podiatrists, I am very busy in the Podiatrist clinics, and the average wait for patients for an appointment for me is 2 to 3 months. That is the reason why what is supposed to be only 4 patients per hour is often 6 or more, with the more urgent patients being squeezed in at the last minute. Because of the lack of podiatrists, the type of patients that I see range in problems from the basic geriatric maintenance type patient, all types of biomechanical issues, diabetic feet, regular podiatric skin issues, pediatric issues, sports issues, and a very large amount of ingrown toenails. The reason I'm telling you this is so that you can appreciate the background to the development of my approach to ingrown toenail treatment. I have gathered over the years a tremendous amount of experience in all ranges of treatment of ingrown toenails, both surgical and non-surgical. I have developed over the years a technique which I would like to share with you, perhaps a slightly different perspective. In my clinics in the public sector, patients often wait 2 to 3 months in order to see me for a few minutes. I don't have the luxury of doing a non-scheduled nail surgery, and doing a PNA or nail resection with finalization requires an extra long appointment booked ahead of time. I often need to remove the ingrown nail on the spot quickly and thoroughly, so that the patient gets relief for as long a period as possible, hopefully without recurrence. When I get someone who has a chronic problem, then I need to schedule a separate appointment for nail surgery at a later stage, often 2 to 3 months later. However, the patient comes in to me in pain, and I need to solve the problem quickly and as thoroughly as possible in order to give the patient relief for as long a period as possible. The technique that I've developed over time that can be seen in the video clips involves the use of nail nippers and a number 15 scalpel blade. In most cases, this is done without the need for local anesthesia. Often, patients comment to me about how they were expecting severe pain, usually based on past experiences, only to be very pleasantly surprised. They often tell me how my treatment was less painful than the local anaesthetic injection that they had the last time. My technique is thorough, goes very deep down the sulcus, and is good for use in all non-surgical treatments. Often a patient who is told that they need nail surgery comes to me, and I manage to remove the problem without nail surgery and without recurrence. Judgment of the podiatrist is obviously required because sometimes it's very clear that local anesthesia is required, and no attempt should be made to treat it without. However, even then, I usually use my method for the anesthetized non-surgical quick treatment. Usually, I say to my patients that there shouldn't be any significant pain, but if they do, then they have to tell me and I will administer local anesthetic. That, however, is very rare. I often get a patient that walks into my clinic in absolute fear, shaking from expectations, tell me right away how much they hate needles. In cases like these, I can really see the benefit of my approach. As can be seen in the video, for preoperative skin disinfectant, I use a spray to apply chlorhexidine, hibitane, alcohol solution. Often, after or during the relatively painless treatment, the patient makes a comment to me about how good that anesthetic spray is. They think that they can't feel anything because I used some kind of magical anesthetic spray. I also think that often podiatrists and surgeons take the approach that there are two options only: very mild nail spike removal or full nail surgery. I think that a lot of nail surgeries are done needlessly, even in first-time patients with often terrible post-operative pain and aesthetic issues, which in a lot of people, especially females, is a very big issue. In my experience, with my approach, there is also another possibility, a non-surgical thorough treatment that can often prevent the need for nail surgery altogether. If the problem recurs, then there's always the option of doing nail surgery at a later stage. However, for a first-time patient, I think that a lot of nail surgeries can be prevented with this approach. In the two clips that you're about to see, the nail has not undergone any local anesthesia. There's a topical application of an alcohol-based skin disinfectant. Now I'm making an incision with the nail nipper. A little bit of an incision, not too deep, because then it will start hurting the patient. Now I stop, and I'm going to take a 15 scalpel blade to continue down the nail sulcus. The blade facing upwards, a very small amount of the blade in contact with the nail, making sure not to cut into the nail bed. Sometimes when there's very high sensitivity and the patient is scared of needles and I don't do a local anesthetic, I use a dorsal approach for this, taking the scalpel blade on the dorsum of the nail, the dorsal aspect, and slowly but surely making an incision and cutting through. Now I'm separating the nail from the nail bed. Removing the nail. Have a large piece of nail there, as can be seen. Now I have to continue to cut down the sulcus to make sure there's no edges. Make sure that the edge of the nail is completely straight on the sulcus and there's nothing that can interfere at a later stage. Then I dress the area and I instruct the patient how to apply dressing for a few days at home. In this case, there was no pain at all. You can hear in the background the patient was quiet. No pain was felt. Okay, the patient presents with a mild ingrown toenail, left foot hallux lateral sulcus. He's had it once before, about a year ago. What I'm going to do is remove the section of the nail that's growing in. I'm not going to do nail surgery. In this kind of case, we very often only need to remove the section of the nail that's growing in and do it very thoroughly to give the patient peace and quiet, and could be that there won't be a need to do a partial nail avulsion with phenolization matrixectomy, nail wedge resection. So I'm just going to take the nipper, make a small incision, then I'm going to take a 15 blade. Very often there's no need for local anesthesia because it will probably be more painful to inject the patient with anesthesia than what the patient is hopefully going to be feeling now. So the minimal pain that we would have over here is usually less than the local anesthesia. That's the section of nail. Now I remove the rest of the side of the nail, ensuring that the nail edge is straight and no edges are left down the sulcus to grow in at a later stage and cause problems. We want to have the patient have peace and quiet for as long a period as possible. When I'm finished the treatment, I apply a dressing and I instruct the patient how to dress it at home. If we see that this is recurrent, that it keeps coming back, then we can think about doing a nail surgery, PNA with phenolization, nail wedge resection. Okay, now I'm going to put a dressing on to take a close-up to see what we've removed. Once again, this procedure was done without any local anesthesia and no pain.